PSIS pin. The robot first does a scan of the environment to define its area of operation and the no-fly zones. The robot navigation registration is then carried out using the snapshot. The navigation array should not be moved after this step. This step is repeated in case intraoperatively you lose navigation accuracy. A blunt passive planar probe is then placed in the region of interest, and the star marker fiduciary array is attached to the robotic arm. The star marker is used by the robotic system to identify the vertebrae in space. As a convention, we at our center place the bone mount on the left side and the star marker on the right side. This familiarizes our team with the workflow and the anatomy for this allows the star marker can be lowered to the maximum, which zooms out and covers more vertebrae. Next, the O-arm is brought in and the patient is fully covered with disposable plastic drape. The 4 beats of the star marker must be adequately visualized on the epilateral X-rays. The 3D images are then sent to the workstation where the screws are placed. The region of interest is marked on the acquired images. The workstation automatically segments the vertebrae, and care must be taken to ensure both pedicles are adequately visualized in each of the segments. The screws are then planned at each segment, ensuring intraosseous placement of the screws in axial, coronal and sagittal sections. This we chose despite the company saying that choose a small case. I always wanted to start big. So we chose a scoliosis case on the 15th of October. She is a 15-year-old girl, adolescent idiopathic scoliosis, Lenke 5 CN, major curves, thoracic and lumbar both measuring 46 and 47 degrees each. 2 O-arm scans were necessary for complete instrumentation. First spin covered T12 to L4 with the pin in PSIS. It is important to ensure that appropriate vertebral axis while planning the scoliosis pedicle screws, as it is a 3-dimensional deformity. You have to derotate the vertebrae. The second spin covered from T6 to T11 and T4 and 5 were placed freehand, and here I used the T11 shank spin placed under fluoroscopic guidance. The post-operative X-ray showed perfect positioning of the implants and restoration of sagittal and coronal balance, and patient was mobilized 6 hours after the surgery. I am going to give one example of each type of deformity that I have done. This is a 36-year-old lady with neglected adolescent scoliosis. It's adolescent onset but adult presentation. She underwent robotic T4 to L4 fusion with 2 O-arm scans to cover all the segments of the spine, and post-operative radiographs showed perfect implant placement and well-balanced spine in coronal and sagittal plane. A 5-year-old boy whom I had done a juvenile scoliosis, whom I have done growth rod distraction from 2018 till 2023. He came back and he was by then 11 years and he underwent he had triradiate cartilage which was fused, and he was ready for the final fusion, and we did a final fusion from T2 to L3 using 2 O-arm spins, and we got excellent implant placement and well balanced spine with full deformity correction. Another interesting case, a 11-year-old child with Klippel-Feil syndrome, occipital meningomyelocele and proximal thoracic scoliosis, double major curve, lumbar is 73 and thoracic is 85 degrees. Radiograph showed that cervical spine showed fused cervical vertebrae, and the first mobile disc was C7T1, and this is the CT scan which revealed multiple fused vertebrae in the neck and a defect in the occipital bone. Looks like a congenital suboccipital craniectomy. Intubation was anticipated to be challenging because she had a short neck and with a chin on chest deformity because of cervicothoracic kyphoscoliosis. So, severe webbed neck with chin on chest deformity. We have a separate dedicated spine anesthesia team comprising of 4 anesthetists catering to only our needs. They were able to intubate with video laryngoscope in this case. robotic assisted deformity correction was planned. 2 O-arm spins were necessary. First O-arm scan covered T3 to T10 and the second one from T11 to L3, and we got post-operative radiographs which showed perfect implant positioning and good restoration of coronal and sagittal balance. Coronal and even the upper thoracic kyphosis was significantly reduced in the post-operative radiographs. The patient was electively extubated following surgery immediate and placed on non-invasive ventilation for 2 days, following which she was mobilized after second day and discharged on the third day. Another degenerative deformity, adult deformity, 65-year-old male with severe neurogenic claudication and weakness of both lower limbs. He had extensive thoracolumbar congenital along with secondary canal stenosis from T11 to L4. MRI revealed similar findings, and patient underwent deformity correction and fusion from T8 to ileum with 2 spins. Here for S2LR iliac screws we had to use FOV40, as visualizing both the femoral heads were difficult with FOV15, which is normally used for. And intraoperative radiographs, this was the first time that we were using the S2LR iliac screws, and they showed that it was well positioned implants. And this is the final X-ray showing a well balanced spine. Diagnosed to have a hemivertebra antenatally, child was born and progressively increasing congenital thoracolumbar deformity till 5 years of age. When they saw us, we did MRIs were normal. We did a D12 hemivertebra excision and D11 to L1 convex hemiepiphysedesis in 2015. Patient was lost for follow-up only to present last year with the sudden progressive deterioration in the deformity at the just before onset of menarche with junctional kyphosis of 77 degrees. The lateral bending X-ray showed the flexibility of the curve, as well as the push prone radiograph showed that even the kyphosis was quite flexible. We did a T9 to L3 posterior spinal fusion using robotic guidance with good implants, good correction of the deformity, and patient walking within 6 hours after surgery. Another 11-year-old girl with severe adolescent idiopathic scoliosis with severe rib hump and type 2 respiratory failure, breathless at rest, 168 degrees thoracic and lumbar 122 degrees curve. No reduction in magnitude of the curve on side bending radiographs. CT scan shows the severity of deformity and also rib crowding at the apex. Segmentation during scan and plan workflow is challenging in severe deformities because the orientation is lost. Planning the screws is challenging too, however, visualization of the adjacent segments makes it easier. So, you come from normal to abnormal. A second scan was done for placing the lower screws. All trajectories at the apex could not be executed due to the severe deformity and inaccessibility of the trajectory through the robotic arm, as the rib hump was coming in the way of trajectory. Post-operative radiographs with good implant positioning and adequate deformity correction in coronal plane and in sagittal plane too. Again, the anesthesia team extubated the child immediately and put on NIV for 2 days, and she was mobilized on third post-operative day and discharged on the fourth day. Another 13-year-old girl with right thoracic curl, quite flexible, 65 degrees, reducing to 47 degrees, and MRI showed no problems. Underwent T4 to L2 deformity correction, and post-operative radiographs revealed well placed implants and restoration of coronal and sagittal balance. Mobilized 6 hours after surgery. Another cervicothoracic neurofibromatosis boy with dystrophic cervicothoracic kyphoscoliosis. Sharp angular cervicothoracic curve suggestive of dystrophic with proximal thoracic curve of 111 degrees and main thoracic of 55-degree curve. Curve was rigid on side bending X-rays, and CT scan showed the magnitude of the deformity. First scan T3 to T5 and the second scan from T5 to T12. And post-operative radiographs revealed that well-balanced spine with the implants in good position and restoration of coronal and sagittal balance, and patient mobilized after 6 hours of surgery. Another 15-year-old girl with double major adolescent idiopathic scoliosis. The main thoracic 54, thoracolumbar was 67 degrees. Side bending showed them to be correcting to 40 and 43 degrees respectively. 2 O-arm scans are necessary for T4 to L4 fusion, and post-operative radiographs showing good sagittal and coronal alignment, and mobilized 6 hours after surgery. Another 15-year-old girl with lanky 5C curve. I think I am going overboard. I just want to quickly finish it. That's why I asked Ajay to split it into 2 halves. She had a lumbar curve measuring 55 degrees, ideal for an anterior surgery, and it was flexible. So we did try robotic assisted anterior instrumentation from T12 to L4. O-arm scan done following anterior discectomy, not before, because there will be a movement after. And we did use the feather touch drill to prepare the track for the screw, as shown here. It is navigable fully. And even the screw insertion, we use the power tool to put anterior lumbar screws. Post-operative radiographs revealed well-positioned implants, both coronally and sagittally. There was good restoration of balance. Learning points from our series of deformity surgeries: we definitely need 2 to 3 spins, and 1 spin can span from 5 to 7 levels. T2 to ileum is possibility, and it is approved for use. Conventional, we use posterior midline open approach. We always flatten the transverse processes in thoracic spine before the O-arm spin. The skiving problem is because of the skiving of the drill over the transverse process. So we have always done this with flattening of transverse processes. The bone mount at the lowest pedicle or PSIS, and O-arm scan with the self-retaining in place, and we always plan in-out in trajectory for thoracic spine, just to reduce the error of judgment. In deformities, unlike in lumbar spine, AP segmentation is more important than lateral, and it's always important that you include all pedicles that are seen. After segmentation, while planning the screws at individual levels, the 3D deformity distorts the appearance of the vertebral segments. The restoration of the normal alignment by adjusting the axis is necessary before planning the screws. The flattening of the thoracic transverse process in axial sections can also be seen there. In case the pedicle in interest is inadequately visualized, the software allows us to see the upper and lower segment, which help us to identify the track that we have to plan. The kyphosis series, this was scoliosis. So kyphosis, this is a 12-year-old boy presented with progressive deformity of thoracolumbar spine since birth, 105-degree angle, congenital scoliosis, reducing to 71 degrees on push prone view. MRI showed no intraspinal pathologies. Traditional scan taken ensuring all 4 beats of the star marker visualized on orthogonal X-rays. 3D O-arm scan sent to the major console where the planning of screws was done. Here, as you can see, the left L3 and L1 screw trajectories were in the way of the bone mount. The mount was then removed and the screws were placed without physical robotic mount. So this is without mount. And following laminectomy, the apex of the kyphosis of the spine was stabilized with the temporary rod, and a repeat O-arm scan was done, as the navigation accuracy would have lost after the rod on one side. and the second scan was done use of navigated burr in doing a posterior column resection, a vertebral column resection, and this is the post-operative deformity correction seen on the intraoperative O-arm scan and the final X-rays, which restored the complete sagittal and coronal balance. And the child had minimal neurological deficit after surgery, and in 3 weeks he was back to being independent on normal neurology. Another neuromuscular kyphoscoliosis, a 10-year-old child operated meningomyelocele with paraplegia, presented with severe lumbosacral kyphosis and fixed pelvic obliquity, type 4 partial sacral agenesis, had Arnold Chiari with FMD, suboccipital craniectomy and duroplasty done in the first stage, followed by the child planned for robotic assisted correction of lumbosacral deformity and instrumented spinopelvic fusion from T3 to ilium. The first spin, actually we could get planning of 9 vertebrae on the top because the child was small in size, and the second spin facilitated placement of 2 iliac screws on either side of the pelvis. And we performed internal gibbectomy following ligation of the dural sac. This is the final construct with excellent correction of the deformity, and clinically this is the pre-op and post-op clinical pictures showing the kyphectomy effect. 10-year-old boy with kyphosis, previously hemivertebra excision done at the age of 5 in 2019, presented after 5 years, progression of deformity with implant backing out. You can see the extent of implant back out. Push prone radiograph showed stiff kyphosis. T9 to L3 deformity correction and fusion was planned and executed with good correction and restoration of sagittal and coronal balance. 33-year-old female with ankylosing spondylitis with T10, T11 pseudofractures and kyphosis proximal to the fracture. MRI showed 3-column injury with minimal cord compression. T7 to L2 posterior spinal fusion with ponte osteotomies along with anterior support using a cage at the apex was done, and you can see a good correction of kyphosis and well positioned implants. A tuberculosis spine with paraparesis, destruction of T7, T8 vertebrae. MRI showed pre and paravertebral collection. Labeling can be challenging in destructive lesions. What was labeled as T7 was a combination of T7 and T8 which is collapsed and destroyed. So we use navigated burr to do an internal gibbectomy when required. Correction of kyphosis also is noted. While physical mounting of the robot does limit inadvertent movement, the robotic arm does allow some additional movement. Therefore, the critical areas like cervical and thoracic spine, it is prudent to visualize the entry points for additional safety. Fractures, 37-year-old male with T6, T7 burst fracture with paraplegia, and MRI revealed acute kyphosis and cord compression, underwent T4 to T8 posterior spinal fusion and decompression. Some tips for doing thoracic pedicles. The risk of skiving in thoracic spine can be prevented by flattening of transverse process and directing the sleeve using the finger so that it doesn't slip. Instrumentation of the central levels before the peripheral end vertebrae. Percutaneous, submuscular and subfacial for the end levels can be useful, and real-time navigable burr also allows 3-column vertebral osteotomies to be done safely. We have our series of S2LR iliac screws because they are the preferred zone 3 pelvic anchor in lumbopelvic fixations. It reduces the risk of pseudarthrosis by extending anterior to the flexion moment of SI joint when accurately placed. Conventionally, the screws were placed with fluoroscopic guidance using, however, robotic assistant allows accurate placement of these screws while minimizing radiation risk to the surgical team. The S2LR This was the first case wherein we struggled to get both the femoral heads in the image because we didn't know that we had to use FOV 40. So this was with the FOV 15, and later we started using FOV 40 and we used it in all cases of S2LR iliac screw fixation after that. And this is FOV 15 and FOV 40, and visualizing the entire ilium is very important in S2LR iliac screws. Again, there are some technical tips. The feather touch drill, the Midasarex is only 30 millimeter, it doesn't cross the SI joint. As you can see here, it just goes and touches till the SI joint. So what we do is, after that we used 4 millimeter tap to cross the SI joint, as it has a sharp cutting tip and it crosses the subchondral bone quite consistently. However, this doesn't go all the way till the planned trajectory, as the shaft of the tap, 4 millimeter tap, is 6 millimeter. So it also has got a stop at 6 centimeters. So then we use the 6.5 millimeter tap to go all along the planned trajectory. We usually normally use 90 millimeter screws for S2LR iliac screws, and then the screw is inserted using power tools so that the toggle is avoided, preventing skiving. You can see it goes so smoothly in between the two tables of the ilium. Intra-op O-arm scan shows perfectly positioned S2LR iliac screws. Here is a 70-year-old failed back syndrome. He is a professor of forensic medicine. Failed back syndrome with congenital and secondary stenosis from T, and we did a fusion from T12 to ilium, and you can see well placed pedicle screws and S2LR iliac screws, and patient mobilized 6 hours after surgery. Broken implants. Spine robot especially is useful in patients with broken implants. It allows placing pedicle screws at the level with the broken implant in the bone by avoiding those areas. Preoperative O-arm scan showing broken left S1 screw and newly planned S1 screw, avoiding the broken screw. And O-arm showing right S1 broken screw with planned S1 screw, which is avoiding the broken screw. And this is the final post-operative screws. You can see those S1 screws which are perfect below the old broken screws. The post-operative radiographs are quite nice. Again, with vertebroplasty cement, failed back, you can plan the screws avoiding the areas of bone cement safely, and radiographs show that well positioned implants. In spondylolisthesis, when placement of interbody cage is required, the robotic navigation allows placement of cages under visualization. We always do mini open, planning of screws in all 3 planes, and main aim is to preserve the superior facet soft tissue attachment, and software can also simulate final appearance after the cage placement. Separate lateral incisions are taken for lumbar screws and the end vertebrae in thoracic spine. Whenever anticipated soft tissue pressure on the robotic arm, the choice was made to use percutaneous, transmuscular, transfacial incisions to prevent skiving. Post-operative radiographs revealed well positioned screws and cages. In long-standing listhesis, there is a sclerosis of sacral promontory. It is important to drill through it, otherwise it is impossible to place tricortical S1 screw, as the screw may not be able to break it and the tulip remains proud. This is especially important while placing the cannulated screws, the legacy screws. One case, Dr. Amit Jhala was in Bangalore, so we had a privilege of having this child, adult lady, 44-year-old lady with back pain, no leg pain, instability pain with a grade 1 listhesis, instability, no. So we planned for a O-lift first, and then we proned the position and did the robotic assisted pedicle screw insertion and fusion. Thank you.